Hello everybody, we are from SGD B3. Today we are going to present our student project about cerebellopontine angle tumor. And here is our group member. And next slide. Cerebellopontine angle or CPA tumor is the most common location for posterior fossa tumor, and it accounts for approximately 10% of all intracranial tumors. The tumor in this location often classified as vestibular schwannomas and meningiomas that are benign. Due to the slow-growing nature of these tumors, symptoms and modified brain function is not immediately apparent. However, the location of the tumor makes a compression of the cranial nerve, resulting in facial numbness or weakness and hearing loss.
Okay, so the cerebellopontine angle is a triangular space in the posterior cranial fossa that houses cranial nerve 5, 6, 7, and 8, along with the anterior inferior cerebral artery. CPA tumors are the most common posterior fossa malignancy, accounting for 5 until 10% of the intracranial tumor. Most CPA tumors are benign. Approximately 85% of CPA tumors are vestibular schwannomas, lipomas, vascular malformation, and hemangiomas, while the most common non-acoustic CPA tumors are meningiomas, epidermoid, and facial or lower cranial nerve schwannomas.
So for the epidemiology, cerebellopontine angle or CPA tumors made up about 10 until 15% of the intracranial neoplasm cases, meaning it's one of the most common intracranial tumors. If we delve deeper, vestibular schwannoma, or also known as acoustic neuroma, accounted for 80 until 94% of the CPA tumor cases. Following it is meningiomas and epidermoids, which respectively made up about 3 until 10% and 2 until 4% of the cases. So the incidence of CPA tumors is generally higher in adults compared to children, with the mean being usually highest in the 60 plus age group. From another study in USA, we also came to know that incidence of CPA tumors among the Caucasian or white people are usually the highest, followed by Asian, Hispanic, and at last, the black population. Though the numbers are not close to the white populations at all. So that's all for the epidemiology. Thank you.
The etiology of CPA tumor are yet to be fully known, but there are studies that found association between people who have environmental allergies and people who works with benign CPA tumor or vestibular schwannomas. CPA tumor are usually differentiated by two different forms. The first one is sporadic tumor, and the second one is one that associated with neurofibromatosis type 2 or NF2. The sporadic tumor, usually presented as 95% of people who have vestibular schwannomas, are manifested in unilateral tumor. And for the NF2, usually people with NF2 are manifested as bilateral acoustic neuromas and usually presented in younger patients. Thank you.
Besides from the normal pathophysiology of cells' uncontrollable mitosis caused by genetic abnormality, the clinical importance of CPA derives from the wide range of lesion that affects this area. CPA tumors induce lateral brainstem deformity, and contralateral cranial nerves are affected, such as the 7th, 8th, 9th, 10th, and 11th cranial nerves. This displacement stretches the anteriorly directed 5th nerves, making it more vulnerable to damage. And the predominant lesions of CPA are 91% vestibular schwannomas and 3% meningiomas. Lipotamus and glioneural hematomas are the two kinds of the hematomas seen in the central nervous system. Lipomartose hematomas are significantly more common than glioneural hematomas, with the majority of them occurring in the interhemispheric fissure. In instances of neurosarcoidosis, cranial nerve neuropathies are the most frequent neurologic consequence, with the facial nerve and the optic nerve being the most affected. Trigeminal neuralgia has been linked to CPA tumors, which can manifest as pain or hyperphagia, and the tumor compression of the 5th cranial nerve root explains this. Decompression can help these symptoms go away.
Vestibular schwannoma often arises near the porus acousticus with the appearance of rubbery firm mass with a pale gray color. On more microscopic view, the tumor consists of spindle cells. These spindle cells have fibrillary cytoplasm and elongated nuclei and are arranged in two ways, Anthony A and Anthony B. Anthony A tissue arrangement is small with elongated bipolar cells and often arranges its nuclei and fibers resembling those seen in meningiomas. Anthony B, in the other end, is generally seen in large tumor tissue and representing as a random gathering of cells which is grouped around foci of cystic change, necrosis, blood vessels, and old hemorrhages. Meningioma has several varieties, including meningothelial, fibroblastic, and transitional. Meningothelial variant consists of syncytial and epithelial cells with poorly defined borders and crassic whorls. Fibroblastic variant consists of firm tumor with spindle cells and undefined cell borders, and the transitional variant consists of both meningothelial and fibroblastic tumor components. Epidermoid tumors appear as cystic lesions with squamous epithelium and keratin components, which begin from sequestrated epithelial cells of migrating optic and otic capsules. Arachnoid cysts consist of fibrous wall lined by meningothelial cells. Lastly, lipomas consist of fatty cells that will cause bone erosions. Thank you for listening.
My name is Julia, with the last three-digit number is 118. I will explain about signs and symptoms of cerebellopontine angle tumor. Cerebellopontine angle tumor can cause a variety lesion on several regions and will present with subtle clinical symptoms at first. The symptoms will appear based on the size and location of the lesion. The most common initial symptoms of CPA tumor is hearing loss, which is unilateral. Now, the symptoms may appear like headache, tinnitus, disequilibrium, vertigo, dizziness, and gait dysfunctions. Last stage of CPA tumor will show a hydrocephalus or symptoms of brainstem compression. Thank you.
For the diagnosis, cerebellopontine angle tumors can be diagnosed based on physical examination, history, audiometric, and radiologic evaluation. CT scan is one of the radiologic evaluation that can be used. It is useful for examining bony involvement. It works up with isointensity, hypointensity, or hyperintensity. MRI is the gold standard for diagnosing CPA tumors. The characteristic that will be used is dural tail sign. If there is suspected large vessel involvement, cerebral angiography can be used.
CPA tumors are commonly benign. It is usually an important challenge to neurosurgeons demanding a careful evaluation about a wide range of possible differential diagnoses. The differential diagnosis of CPA tumors can be vesicular schwannoma, meningioma, epidermoid, non-vesicular schwannoma, congenital, vascular, and metastatic lesions. CPA tumors can be result from extension of tumor from enhanced regions. It can transform to ependymoma, choroid plexus papilloma, brainstem glioma, or hemangioblastoma.
Next is imaging of CPA tumor. Different imaging modalities lead to a more adequate diagnosis and determine the management. MRI evaluating the malformation in brain, which the sensitivity and the specificity are more superior than CT scan. MRI evaluates the shape and margin, extent, mass effect, intensity, and nearby bone region. CT scan usually performed in evaluation of non-specific symptoms related to CPA tumor. CT scan has great evaluation of bone and airfield space, but difficult in differentiate fluid, nerve, and tumor without contrast. Next is vestibular schwannoma. On CT scan, often isodense and may show erosion or remodeling of adjacent temporal bone, and it's hard to see in non-contrast CT scan. On MRI, it shows isodense signals on the one-weighted image and intermediate to hyperintense signals on the two-weighted image. Next, meningioma often arise from posterior dura. On CT scan shows hyperdense mass with calcification, and on MRI shows isodense mass with dwarf tail features on the one-weighted MRI image. Next, epidermoid on CT scan shows hypodense lesion with irregular border. On MRI shows imaging characteristics similar to cerebrospinal fluid, which are hypointense on the one-weighted image and hyperintense on the two-weighted image.
Now let's talk about the complications. CPA tumors are usually benign and slow growing. Its severity depends on the size, location, and consistency of the tumor. Late diagnosis may lead to difficulty of preserving the cranial nerve and poor prognosis. Post-surgery complications are common due to the position of the cerebellopontine angle that exposes many vital areas of the brain. Most common post-surgery complications are surgical site infection, wound dehiscence, sepsis, blood loss, and deep vein thrombosis. Other post-surgery complications such as headache, stroke, hemorrhage, infection, vascular injury, cranial nerve injury, tumor reoccurrence, CSF leak, and even death. Radiotherapy may also cause complications such as worsening in hearing status, cranial neuropathies, hydrocephalus, and brainstem injury.
There are several treatment methods for CPA tumor. Observation, radiation therapy, and microsurgery are often used for treating CPA tumor. However, observation is only favored for elderly or unstable patients with no measurable growth of tumor. Using observation approach, the cranial nerve function preservation cannot be guaranteed. Radiation therapy can be used as it provides control with low recurrence rate with the cause of increased side effects such as worsening of hearing and cranial neuropathies. The more definitive solution would be microsurgery. Microsurgery aims for complete tumor removal as it can preserve hearing function. It has three approaches. The first one is retrosigmoid, which is S-shaped scalp incision behind the ear. Second one is middle fossa, which is right middle fossa craniotomy. The last one is translabyrinthine. It removes all soft tissue from the lateral cranial base and removing all bone over the middle fossa dura. The different approaches can also be combined, as with the case of combining retrosigmoid approach with translabyrinthine approach if the sigmoid sinus is not dominant.
Now I will explain about the conclusion of cerebellopontine angle or CPA. CPA tumors can be diagnosed based on several ways: physical examination, history, audiometric, and radiologic evaluation. Here, MRI is the gold standard in diagnosing CPA tumors. There are some complications that can happen in CPA tumor. Post-surgery, it can cause surgical site infection, wound dehiscence, sepsis, blood loss, and deep vein thrombosis. Cerebellopontine angle or CPA tumors are the most common malignancy that happens in the triangular space in the posterior canal fossa. And the etiology of this disease is not fully known yet. Cerebellopontine angle or CPA tumors are only presented as subtle clinical symptoms at first, and the symptoms will be based on size and location of the lesion. In treating CPA, we can use observation, radiation, and microsurgery. That's it from me. Thank you.